Okay, let's jump right into this explainer. Today, we're basically playing clinical detective. We've got a high-stakes puzzle on our hands, a critical postpartum emergency. We're going to break down exactly how a trained pro looks at a handful of clues and makes a split-second, literal, life-saving decision. So take a look at this. It might seem like just your standard OBGYN multiple-choice question, but we're going to treat it like a live crime scene. This isn't just about rote memorization, right? It's pure applied logic. We've got a rapidly unfolding emergency, some initial provider actions, and a patient who is absolutely not responding the way we want. We'll analyze every single piece of this scenario to figure out the exact why behind the correct move.
Section 1. The postpartum emergency, establishing the timeline. Let's break down the sequence of events here. Step 1. The inciting event, the birth of a neonate. But almost instantly, we hit Step 2, and it's a massive red alert. The client starts experiencing excessive bleeding, classic postpartum hemorrhage. This obviously demands immediate action, shooting us straight to Step 3, where the healthcare provider issues emergency orders to try and stop that blood loss.
Section 2. Analyzing the interventions, the provider's strategy. All right, so the provider throws two immediate interventions at this bleeding. First, they go physical, with an order for a fundal massage. You're literally massaging the top of the uterus to force it to clamp down. Second, they go pharmacological. They order an IV infusion of 10 units of oxytocin running at 100 milliliters an hour. Now, as you know, oxytocin is a powerhouse hormone for getting uterine muscles to contract. The strategy here is crystal clear. Hit it with mechanical force and medication to squeeze that uterus tight, which, theoretically, pinches off those bleeding blood vessels.
Section 3. Evaluating the clinical clues, the nurse's assessment.
Now it's time to assess the aftermath. Our first clue, vital signs. The patient's blood pressure is sitting at 135 over 90 millimeters of mercury. Now, you'd probably expect blood pressure to absolutely plummet during severe bleeding, right? But here it's actually a little elevated. That tells the nurse something vital. The patient hasn't totally crashed into hypovolemic shock just yet, but make no mistake, the situation is incredibly unstable.
And here's where things get really interesting. The nurse assesses the uterus and finds three major red flags. First, it's boggy. That's medical shorthand for soft and spongy. Basically, it is definitely not contracting like it's supposed to, even with the massage and the oxytocin. Second, it's sitting way too high, about 3 centimeters above the umbilicus. And third, and seriously pay attention to this one, it's displaced specifically to the right side. Our final piece of evidence is the perineal pad, and it's completely saturated with bright red lochia. That means active, heavy, fresh bleeding. So our worst fears are confirmed here. The initial 1-2 punch of fundal massage and oxytocin, it completely failed. The bleeding is continuing completely unchecked. So, with all these clues on the table, we've got to ask, what is the most urgent, logical next step for this nurse? We've got an actively bleeding patient, failed treatments, a boggy, abnormally high uterus, and that weird displacement to the right side. What exactly are we missing here?
Section 4. Unlocking the next action, finding the smoking gun.
Okay, looking at our options, the correct move is to assess the client for a distended bladder. Now, hold on. That might sound totally counterintuitive at first, right? Why are we checking the bladder when the uterus is the thing doing the bleeding? Well, this is where a little anatomical deduction comes in to save the day.
It all goes back to that one super specific clue, the uterus being displaced to the right. That is the ultimate anatomical tell that the bladder is full and physically in the way. Think about the real estate in the pelvis. The bladder sits right in front of and slightly below the uterus. When it fills up with urine and becomes distended, it literally acts like a balloon, pushing the uterus up and shoving it over to the right. And here is the absolute kicker. A uterus that is being physically wedged out of place by a full bladder just cannot effectively contract.
Section 5. Why other options fail, the process of elimination.
Let's look at why the other options are traps. If you crank up the oxytocin or keep pushing on the fundus, you are completely ignoring the root cause. You can pump in all the meds and do all the massages you want, but if a full bladder is physically blocking the uterus from shrinking, it's just not going to work. You have to remove that mechanical obstruction first. And what about just continuing to monitor blood pressure? That is way too passive. This patient is hemorrhaging. They need a direct intervention, not just observation. Checking for a distended bladder is the only action that clears the physical roadblock here.
So it leaves us with this incredible thought. How does one tiny, subtle detail, like a simple shift to the right, completely alter the trajectory of emergency care? I mean, it just perfectly highlights the brilliant rapid-fire deduction required in clinical settings. It proves that real medicine isn't just about blindly throwing treatments at a symptom. It's about spotting the clues, knowing the anatomy inside and out, and attacking the root cause. Next time you're faced with a stubborn problem, think of the displaced uterus. Sometimes the real solution means looking just slightly adjacent to the obvious issue. Thanks for joining me on this explainer. Keep questioning everything, and I'll catch you next time.